Greetings, good morning, good afternoon, and good evening, wherever you may be in the world. My name is Brian Smedley. I'm a senior fellow in the Health Policy Center of the Urban Institute. Welcome to this Urban Institute webinar, The Past and Current Social and Political Context of Health Inequities. This webinar is part of a series of webinars and commission papers that we've released as part of our 20-year retrospective looking at the 20th anniversary of the publication of the Unequal Treatment Report by the then Institute of Medicine, now National Academy of Medicine. This report, published in 2003, found compelling evidence that people of color receive a lower quality of healthcare even after controlling for or accounting for access-related factors such as insurance status or income to pay for out-of-pocket costs. We're delighted to bring this webinar to you today as part of this series. Before we begin, just a few housekeeping notes. First, this event is being recorded and the recording will be posted online afterward. Closed captioning is enabled. You can adjust the settings with the caption button. Our speaker biographies are available online at urban.org. All participants are muted, but you can type your questions and comments into the Q&A box at any time. Please take 1 to 2 minutes to complete the survey at the end of this event. And lastly, please engage with us online using the hashtag #LiveAtUrban. I want to invite our distinguished panelists to join me on camera as I introduce each of you. Our speakers include Dr. Camilla Mateo. She is a primary care pediatrician at the Martha Elliott and Boston Children's Hospital. Dr. Marie Plesme, research fellow at the FXB Center at Harvard University. Dr. David Williams, a professor of public health and African American studies and sociology at Harvard University. And our colleague here at the Urban Institute, Dr. Karishma Furtado, an equity scholar and senior research associate in the Health Policy Center and Office of Race and Equity Research. This webinar will discuss the social and political context of the last 20 years since the Unequal Treatment Report was published. Our speakers will discuss the findings and how we begin to move forward in a period of political backlash to progressive movements. We're very excited and delighted to feature this webinar today. So let me thank our speakers in advance. And now I'll turn to my colleague, Dr. Karishma Furtado. Thank you.
Thank you, Brian, and thank you to all in the audience for joining us today. I am coming to you all from Fort Lauderdale, Florida, so pardon any sort of beachy background sound you might hear, but on the other side of my screen is the Intercoastal and the ocean, and it is a beautiful place. Less than a month ago, the governor of this beautiful state cheered the University of Florida's announcement that it had fired its entire DEI team. Florida, Governor DeSantis said, is where DEI goes to die. Many of us working in and around the healthcare system to improve health disparities worry about the implications of such a policy environment. Some of us struggle to put the backlash against race consciousness into context and to make sense of it so that we can move forward. The paper my colleagues and I worked on grappled with these same challenges and realities. The Unequal Treatment Report followed a raft of other reports, initiatives, and policies in the 80s and 90s that documented and decried racial disparities in health outcomes, oftentimes while staying a comfortable distance away from the word racism. When the report came out, it provided unflinching evidence that healthcare systems, as Brian mentioned, and the people within them were providing inequitable care to individuals based on their racial and ethnic identities, and that the issue wasn't just access to care. Provider bias, stereotyping, and prejudice were all issues contained within the healthcare system that were implicated deeply in health inequities. Healthcare providers and institutions could no longer attribute racial and ethnic inequities to health to factors considered beyond their purview. In the 20 years since the report was published, the conversation has gone even further upstream to the institutional and systemic structures that drive inequities, including structural racism. All of these efforts across the decades have existed alongside and been shaped by a steady stream of opposition. And today, that opposition can feel more like a powerful river. Anti-DEI policies like those here in Florida, the dismantling of race-conscious admissions following Supreme Court decision against affirmative action, immigration policy that increasingly adopts right-wing rhetoric, reproductive rights that are vanishing, limitations on LGBTQ protections are all just some of the ways in which we see a social and political norm that's shifting away from equity. The paper that my colleagues and I published critically reflects on how the socio-political context at the time of the report and since has impacted the implementation of the report's recommendations to eliminate racial and ethnic inequities in care. We're not going to spend a bunch of time lecturing you on what we put in that paper. Instead, I'm hoping with our time today that we can have a conversation about what the Unequal Treatment Report and other efforts like it represent, while also making space for the areas of progress and promise that my colleagues each see from their different vantage points in the healthcare system. So I'm going to turn to my questions for you all, but to the audience, please do share your thoughts and your questions in the Q&A box, because we will be saving about 20 minutes of our time for discussion of them. So with that, I'd like our opening question to be one of reflection. How do each of you from your different spaces relate to the Unequal Treatment Report? What does it represent to you 20 years after its publication? And David, I think I'll start with you as a contributor to the report and as obviously a very established scholar of structural racism and health.
Thank you so much, Karishma, and it's good to join the audience today. I would say that the Unequal Treatment Report, when it was released in 2002, published in 2003, was a landmark report. It was a report based on scientific evidence coming from the Institute of Medicine, now National Academy of Medicine. What did the report find? Across virtually every therapeutic intervention, from the most simple to the most complicated, Black people and other persons of color in the United States received poorer quality care and less intensive care than whites. Those differences persisted even when you look at people at the same stage of disease. If you look at people with the same level of insurance, it was not an issue of access to care, it was differences in quality. And 2023, last year, marking 20 years, I am deeply distressed that we have not made more progress. On the one hand, the report got a lot of media attention. It was on the national news across the United States. There was awareness raised, and many healthcare organizations began to implement initiatives to address the underlying problem. But the problem persists. And just to give the audience one example of how the problem persists, I want to tell you about a study published in 2023, so 20 years later. It was a study of 318,000 Medicare patients, so they all had the same health insurance, and they all had the same condition. They were dying with cancer in the last days of their life. And the question the study asks, does the race and ethnicity of the patient determine whether they get pain medication or not? And what the study found was that African American and Latino patients were less likely than white patients to get opioid medication for their pain. And when African Americans and Latinos got opioid medication, they got a smaller dose. And African Americans were more likely than other patients to have to undergo urine drug testing to see if they were abusing opioids. And African American males were the single most disadvantaged, being the least likely to get pain medication and the most likely to get urine drug testing. It's just one study, but it illustrates the persistence of striking racial differences in a country where we believe that all of us are equal, and every healthcare provider takes an oath to provide outstanding healthcare for all of their patients, but yet this pattern persists. So I am distressed that it still persists, but I am not immobilized. And I think meetings like this are so important to raise awareness levels that we have a problem, and then let's work unitedly and energetically towards the solutions.
Thank you so much, David, for that. Turning to you, Camilla, as a physician who thinks deeply about how we train other physicians in addition to our direct practice, how do you make sense of the Unequal Treatment Report? What does it represent to you?
Absolutely. I remember learning about the Unequal Treatment Report in my training, and honestly, it was inspiring to me to understand that this group of interprofessional thought leaders in health had prioritized the topic in their work. Much of what brought me to medicine was a desire to use science and direct clinical care to address social justice issues, in particular for me, health disparities. And so it felt validating as well to read that this was an important issue long before that was recognized long before I ever even thought about joining, medical practice or health professionals in general. And to see it be prioritized by groups of people that I really admired and that I looked up to was actually very motivating for me to continue to contribute to this work as I was going through my training and beyond. As an educator, I actually often use the Unequal Treatment Report in my teaching to try to invigorate others the way it invigorated me as a trainee when I was learning about it. I use it to anchor conversations about the progress that has been made in this space, as well as to motivate learners to contribute to the work that's left to do. What are the unique ways that your perspective entering this practice or entering this particular type of practice is going to be able to contribute to gaps that remain? And so it's actually been really helpful both in my direct practice, but also in keeping me motivated to continue working in this space.
Thank you for that. And Marie, how about you? As an earlier career researcher studying racial bias, training in medical education and clinical practice, how do you relate to the Unequal Treatment Report and where it stands 20 years after its publication?
Yeah, thanks, Karishma. The report, when I first learned about it, was super foundational to the work that I do now. I remember being in my different master's classes and thinking about, like, we're learning about how the health of different populations are impacted by different factors. But in my head, I was like, racism and racial bias and discrimination have to play a role. We weren't talking about it in the classroom. And then I found this report and like similar to Camilla, I felt validated, like, yes, someone's actually talking about this. And I think I'm also in the David camp where it's disheartening 20 years later. We're still trying to convince people, even though there's so much data that documents that this exists. And so I feel like as my job as a researcher is to really develop evidence-based interventions to not only show and document the problem exists, but figure out, like, how do we create policy solutions? How do we develop data so that we can ensure that we're not talking about this 20 years from now, and that it can we can reduce stereotyping and bias in ways that are feasible.
Yeah, so definitely hearing themes of both the importance of the report as a galvanizing tool and the heaviness of the fact that so much of what it found still remains entrenched in our healthcare system and the individual outcomes contained within it. So let's stick with that theme for a moment. And I should mention to the panelists, if you ever want to speak to one another's responses, please don't feel overly constrained by my questions and my ordering. So conversation is very much welcome. But as several of you have mentioned, Brian mentioned earlier on, in many ways, the health disparities that the Unequal Treatment Report documented remain intact, and some even have grown. David, your example of pain treatment for end-stage cancer patients is a stark and appalling reminder of that, an example of that. Can you each share on why that is? What are some of the deeper reasons that you see from your own practice and research and contained within our paper for the entrenchedness of those disparities? And Camilla, why don't I start with you this time?
Absolutely. I think there are many reasons that we can draw upon. I think one that comes to mind that we focused on our paper as well was a lack of focus on structural drivers of inequity like racism and others in favor of a narrative that focused on the individual and personal responsibility. Although we saw an increase in documenting racial disparities in health certainly in the 80s and 90s, there was this reluctance to name racism and other drivers, as you mentioned, Karishma, that were underlying these inequities directly, instead really focusing on these individual drivers of things like personal choice as a culprit for some of the disparities that we're seeing. And while individuals and communities certainly have agency, this narrative and interpretation of disparities as a reflection of the individual or community affected isn't aligned with the evidence we have of major structural drivers patterning health between populations that has been built over decades, and that was certainly present in the 80s and 90s when the documentation of these disparities, when there was an uptick in the documentation of these disparities. And as we know, the questions we ask often shape the answers we get. If my hypothesis is that the individual is the point of focus, my interventions will likely focus there, missing an opportunity to address these larger structural issues more directly. And so I think that's one of the patterns that we saw when we were working together on this paper and thinking through some of the barriers that came up over the last 20 years.
Thank you for that. Marie, taking that where Camila leaves it off, how has the diagnosis of what's at play moved somewhat upstream into the interpersonal dimensions of bias, as you've learned from your work studying bias in medical training, and any other thoughts you have to the original question as well?
Yeah, I think in addition to, as Camila mentioned, the national discomfort or like discomfort we have about talking about race and racism, I think we also still have a fragmented healthcare system, right? And unfortunately, as COVID pointed out, there are cracks that have exacerbated different disparities for different racial groups. And then secondly, I think the question of data and tracking, like exactly to Camila's point, the types of questions we ask are going to lead to certain responses. And so we have documented heavily that racial bias does plays a role in how patients receive care, the quality of care. But what about public health interventions that can show how we mitigate those problems? And the report originally focused on Black Americans, but there's several other racial groups that also need data and tracking. And so I think there's lots of opportunities for exploration, and the fact that we haven't gotten there has pointed out the different fragments within the system.
Yeah, and I would add that I completely agree with what my colleagues and co-authors of this paper, and I would encourage individuals to get the paper and read it. It will has much more information we can share with you today. But the important point too is that a lot of what we are doing is not working. So what has been the response of the healthcare system in the United States? Implicit bias training and diversity, equity, and inclusion training. Now, that is under attack. And to me, the fact that it's under attack is preposterous in the sense that what's the rationale for why so many on the political right are opposed to diversity? Because they think it is a strategy that will discriminate against whites and that is disadvantaging whites. Just to give you one data point, in 1965, 2.9% of physicians in the US were Black. Today, 5% are African-American, 6% are Latino. We have not made much progress, so I'm not sure where this worry about the disadvantaging of whites is coming from, given the actual reality of limited progress we've made in reducing inequities. But let me go back to the point of the diversity, equity, and inclusion training. These 1 hour, 2 hour workshops that are done, research has studied them and have summarized the impact. They are useful. They are useful in raising awareness levels that inequities exist. They are useful also to some degree in building support for addressing them, but they are not effective in reducing bias and in reducing the implicit biases and the discrimination that leads to these differences. And I like in my lectures to talk to people about the Devine solution. Professor Patricia Devine from the University of Wisconsin at Madison has developed a program that is successful in reducing implicit bias. And what is different about that program? It's not a 2-hour workshop. It's a 12-week program where people have homework exercises where they have to practice. Those who practice are more successful in reducing the bias. So importantly, what it illustrates is that for deeply ingrained, often unconscious behaviors, a 2-hour workshop raises awareness levels but doesn't change behavior. And it takes a much stronger commitment to do it. And by the way, it's not only at the individual level we need to work, we also need to work at a systemic level as well. But my bottom line is that we have raised awareness levels, but as a society and as healthcare institutions and healthcare professionals, what we have done to solve the problem is not going to give us the solution that we want.
Camilla, Marie, or David, are there any other thoughts that come to mind about where we may be as a healthcare system misspending our attention, our resources, if the goal is to improve these kinds of disparities? And then in a moment, we'll get to where we should be investing. But what are some of the other things that have attracted our attention, our investment, that perhaps aren't worth it?
I might reframe it a little bit in that I am someone who sees these interventions as not necessarily an either or, but not sufficient. In thinking about not necessarily to look at the investment that's been made in some of these approaches, and perhaps they aren't changing behavior, for example, in the way that we would like them to, or perhaps we're having trouble measuring the behavior change that we would like to see, for example, because we aren't necessarily incentivized to study medical education interventions in the same way that funding exists for other interventions in public health. But instead to think about where are places where we can continue to address and to think about structural drivers as well. And so if I'm interested in creating individual level practices that can minimize bias from creeping into my clinical practice, I think that's absolutely wonderful, and finding ways to make those longitudinal and to make those practices and habits stick, like taking from Dr. Devine's work and putting it into health professional training is absolutely a part of that. I think it's just that in addition to that, it's thinking about the environmental changes that would serve to also mitigate bias. How is it that the places that we practice, the places we provide direct care, how is it that the pressures that exist there, whether they be time, whether they be emotional pressures or otherwise, how is it that we can help to create an environment that actually enables us to use those individual level behaviors the way that we would want to with patients? And so I think it's thinking about a both and, seeing where are the places that we can create environments that actually enable us to put into practice the things that we've seen be helpful in one-on-one interactions in mitigating bias, is I think a place where I would be thinking about putting more resources.
One other point I would mention is that there is a thought in some circles in our society that these processes of implicit bias and explicit bias, for example, are not real. They're fake news. And there is one study from the United Kingdom that I found quite striking. It was a really high quality study, randomized, double-blind, placebo-controlled study of 36 physicians. And they wanted to reduce implicit bias in the physicians. And what they found was that one dose of a beta blocker reduced implicit bias in those physicians for the next hour or two. I don't think it offers us a solution. I don't think we can medicate the rest of the healthcare providers in the world for the rest of their life. But the fact that we can intervene on this process with a pharmacologic agent suggests there are real processes existing in the brain that are causing these dilemmas that leads one of the contributors to implicit bias. So it's not fake news, as some says, to talk about implicit bias and to talk about this discrimination. It is real. It is so real that we can intervene on it with a pharmacologic agent. So it's real, and we need to really commit ourselves to what we can do at the individual level, but also commit ourselves to what we need to do at the structural level to create an environment that will be supportive for every patient who enters healthcare context.
Thank you for that eye-opening reminder, or a realization that there is something very real behind the end product of health inequities, rampant health inequities. Let's spend a little bit more time talking about systems change. You have each, in your own words, and together we in the paper, spoken compellingly about how the goal here really needs to be more than trying to change individual behavior. We really need to build systems, build structures that produce the kinds of patterns of behavior that we want to see at scale. So can we talk a little bit about how we change systems to advance racial equity from a policy standpoint? How do you think we can change the conditions of systems to change the outcomes that they produce? This is an open call, so if anyone feels readier to go than another, please do.
I'm letting one of the ladies go first.
I could go for something that I really enjoyed learning more about in working on this paper with each of you, was learning more about the rich literature that exists around communication of disparities, and how the communication of disparities in thoughtful ways may be a lever that perhaps has been underutilized over the last 20 years to really think about building coalitions to do this work together, and collectives to do this work together. And so, we thought a lot about the recommendations of the IOM report, and several of these, the first ones actually were about increasing awareness about disparities among the general population and also among healthcare professionals and professionals in training. And what we found as we looked through the literature is that even though awareness has gone up in terms of the amount of media coverage, for example, of health disparities compared to when the Unequal Treatment Report was being created and released, has gone up, that we aren't necessarily seeing gaps close, or the measure or the interventions to address them, upticking in the same way. And that some of this might be due to the way that we communicate about health disparities and how it may or may not motivate folks to address them. And so within this literature, of which we only scratched the surface, I'm sure, several studies really indicated that the way we frame discussions about health inequities, for example, the tendency to focus on behavioral causes of health outcomes rather than structural causes in media or in other communication, or the way that at times there's an emphasis on specific events or individual cases, that this can really lead audiences receiving that information to respond to it in ways that aren't aligned with public health goals. For example, like individuals seeing themselves as, immune to the negative health outcomes if they're not part of the, quote, at-risk group being discussed, leading perhaps to behaviors that aren't in line with what we recommend as a public health community, or folks blaming inequities on communities affected rather than on structural drivers of racism or other inequities of opportunity that could be addressed through large-scale mediation, like government intervention, for example. And so I think one of the things that I really enjoyed learning more about in creating this paper was thinking about the ways that perhaps communication and the way we think about communication, the way we collaborate with folks who are experts in communication, both within the health field but also outside of it, might be a lever that we could work with to help bridge some gap in understanding or gaps in motivation that exist across our population here, to be able to actually work on this as a collective more effectively.
I would add that one of the changes that we need in terms of the structural changes is to increase the diversity of the healthcare workforce. I mentioned that before. We have not made that much progress. Latinos, about 19% of the United States population, 6% of physicians. African Americans, about 16% of the population, 5% of the physicians. We need, and it's not just the physician workforce that is like that. If you look at the nursing workforce or the pharmacy workforce, or other health professional groups, you see exactly the same thing. We have high quality scientific evidence that when there is what we call racial concordance between the provider and the patient, there is greater engagement with healthcare. One example of a study that we cite in our paper is a randomized controlled trial. Again, high quality scientific evidence that took 1,200 African-American men on a Saturday morning, give them a coupon to go to a nearby healthcare center for a healthcare screening. When they got to the center, they were randomly, by the flip of a coin, saw either a Black provider or a provider of a different race. And what the study found is when there was racial concordance, when a Black male saw another Black provider, there was greater engagement with the healthcare system, talking about other health problems and the presenting problem, in taking advantage of all of the screening tests that were offered. So there was just, and there's research by Lisa Cooper, again, that finds, there is greater engagement and greater, better quality of social interaction. On the other hand, there is also research that says, in the meantime, until we get there, that providers who are, this study looked at what they call cultural competence, providers that they studied patients who had HIV and looked at there were racial disparities in receiving the appropriate treatment and taking the treatment as the patients were supposed to do it, and with the patient working. So across 3 domains, there were disparities. However, when they reanalyzed the data, regardless of the race of the provider, when cultural competence was high, there were no racial disparities. What did it mean to be high in cultural competence? Providers high in cultural competence as providers who said that social history contributed to how they treat for their patients, that they were familiar with the beliefs their patients had, that they asked their patients about alternative therapies they use, that they find out what their patients think is the cause of their illness, that they involve their patients in decisions about their healthcare. Those are some of the 20 questions that enable someone to be high in cultural competence. And what do you see that is the golden thread that runs through that perspective and those kinds of answers? It's a provider who respects their patients, who engages with their patients, who listens to their patients, who collaborates with them. And when those conditions exist, then there weren't racial disparities in care. So there is a lot that we can do then in recruiting a more diverse group of providers and in terms of training providers more effectively to be better at meeting the needs of their patients.
I would also like to add in addition to thinking about the training of providers, of thinking about the folks who work in the system, through a lot of the work that I do, providers often talk about burnout and mental health. And so how do you make structural changes within a hospital system so that folks aren't feeling overwhelmed, feeling underworked, underappreciated? I remember early on in our conversations, what I also appreciate about our group is that it's so diverse, as Camila talking about the time changes of seeing different patients. And so how does time and the interaction with interacting with your patient, how does that then lead to poor or better health outcomes? So I think there's different levers, as both of my colleagues talked about, that we need to address from a larger scale, but also the policies and systems at play at hospitals themselves.
I'm gonna tie my last 2 questions together, I think, and to give us time for the questions that are coming in the Q&A. So please, if you have any thoughts, put them there, because we will turn to those in about 5-7 or so minutes. But I want to hear from you each about where you see promising efforts. Where do you see examples of things that people are doing in the healthcare system that are making a difference? And then actually, I think I will save our final question for our final question, but it's too hard to lump them together. So, David, can I start with you on that? Where do we see examples of promising practices, policy structures? You mentioned the divine solution. What else comes to mind for you?
I'll tell you about one experience that was quite striking for me. Years ago, I was invited to Wichita, Kansas, to see a community health and wellness center. And it was the work of a nurse practitioner by the name of Arnitha Martin, who single-handedly went to the business community and raised the money to build a community center in the African-American community, which she had grown up in and where she had not received high-quality care. And she wanted to make a difference for that community. And I walked into the center, and I felt like I'd walked into an African art gallery. The beautiful pictures that existed on the wall as I walked down the hallway. And then I learned that this center had developed a strategy to ensure that every person who entered their doors knew that their insurance status or whether they could pay for the care had absolutely nothing to do with the care they would receive that day. Why? Because no question was asked of a patient about, do you have insurance? How are you going to pay for your care? Until their final stop at the clinic, when they had received all of the care that they already had. And they had used a sliding fee scale for persons who didn't have insurance, but they also developed some innovative strategies. A patient could get $10 off of their bill for every 1 hour that they volunteered at the center. A patient could get $10 off of their bill for every hour that they spent in a health education, a wellness class that the center had. So what I cite that example only to say it's a dramatic example of turning our healthcare system upside down, of giving a different set of priorities. And we need to think big and think innovatively of the ways in which we can do things differently. And I laud Arnitha Martin as a trailblazer that did something so dramatic that made a difference for her community in the quality of care that every person received and in the way in which everyone was treated with dignity and respect.
Thank you, David. Camila, Marie, any other thoughts on examples of structural intervention, systems interventions that you find promising? Not, we can shift to my closing question before we get to the audience questions, which I see there are a lot of, which is another reflection question, so bookending my questions for you with the reflection. Imagine it's 2043, so 20 years again from now. 2043 is 19 years, so 2044, let's say. When our future selves or the next generation of us reflect on what we did differently that turned things around, what will they say? What would you like the state of health equity to be? And what milestones or markers will we see along the way to it? Marie, can I start with you on this one?
I think I'm really frustrated with this question because of the current moment that we're living in now, especially the opening remarks of Governor DeSantis and like the real physical consequences of denying folks of their humanity, and how even though like race or racism may be uncomfortable for some folks, it has real tangible consequences. And so I struggled with this question because I'm still trying to figure out what sorts of data points we need to make those changes. And I was also reflecting on your last question about structural changes. I was thinking about the Brigham study or the heart failure study where they randomly placed groups or Black patients in different groups and we saw better health outcomes. And so I think there's real opportunities if we are able to collectively work together, whether it's physicians or researchers or professors, and work collectively to create a tangible solution. But I think it's a matter of first coming together, acknowledging the problem exists, and find ways to document the solutions to do that.
Thanks, Marie. Camila?
Yeah, I think I hear you, and there's a lot of what you're saying really resonates with me. I found it a little bit easier to wrap my head around maybe some of the markers I'd be looking for, some of the conversations I'd love to hear, thinking about, I hope that, they'll look back and say, oh, they started asking the right questions, they started naming racism and other drivers and actually asking questions about that, started focusing on processes, thoughtful processes, and not just outcomes in terms of measurements, started looking at our own practices and norms within health fields, and how some of those practices and norms of the way that some of our projects are funded, the way that care is funded, actually is a big part of the problem. And maybe we should be looking at our own spaces, as well as looking outside of the healthcare space. And I hope that they'll look back and say that we were thinking critically about how to communicate and collaborate with people outside of health, outside of academics, in order to do the types of things that we're talking about that are different, and paradigm shifting. But for me, I also default to thinking about my day-to-day in providing care to patients. And I do think that some of the markers might be more subtle. And I'm thinking a little bit about Dr. Jack Geiger, who is an incredible person, or was an incredible person, also wrote an incredible paper included in the Unequal Treatment Report, where he really listed a lot of the evidence that we're talking about today. He also listed a lot of the small changes that healthcare providers in particular could engage in to stop racial bias from creeping into our day-to-day life. And he actually said small changes in the daily forms of practice consistently adopted can change the culture of medicine. And I think about that quote a lot, because in addition to a lot of what we're talking about, these structural paradigm shifting ideas and interventions, I think especially for those of us who are providing direct care, asking the research questions, implementing the ideas, I think we can't lose sight of doing the next right thing, day to day, that's aligned with our values of providing equitable care, creating the conditions where these actions are supported and celebrated. So the markers that I'm looking for would probably be changes that allow me to spend more time with my patients, so I can take more time to listen to their concerns, changes that allow them to come see me when they need to and not waiting until they absolutely have to. Having resources available to me, because I'm someone that they might see more often as a primary care provider, to help patients navigate social needs that can help them thrive. And so in addition to many of the structural changes that we've been talking about today and that we explore in the paper, I'm really excited to see some of those markers as well.
Let me add to the brilliant ideas already shared by my colleagues that I would like 20 years from now to see that as a society we have made progress. And I recognize that the progress is not going to come easy, and it will not come if we do nothing. Every one of us who's listening here, we can make a difference, and we have to be committed to making a difference. One of the things that I have done for more than a year is the Equal Justice Initiative in Montgomery, Alabama. Brian Stevenson, on his website, there's a calendar. And you can go to that calendar and sign up. And every day you'll get an email of what happened in history, some injustice that took place for persons of color and other disadvantaged people in this country. And I think we have to be reminded that we are standing on the shoulders of those who've gone before us. Even with the problems we face, it was worse for them. And many of them gave their lives to open the doors that we walk through. And we owe it to them to honor their legacy by continuing this important work. So this is no time to become discouraged because of what Texas and Florida is doing. Let us redouble our efforts. Let's gain courage from the weakness and short-mindedness short-sightedness of others, and let us recommit to work together to build a healthier America for all, so that in 2040, my grandchildren will have a better time than people today. So I think it's all of us working together is what is needed to do what we need to do for this country.
Thank you all for those responses, for those words of encouragement and strength. That wraps my questions for you all, but we have a wonderful set of questions from the audience that we're going to try to make a dent in. We might not be able to get to all of them, but let's see what we can do. This first one has to do with training. Training of healthcare workers, including public health students, oftentimes doesn't really engage with structural determinants of health, and instead focus on some of the more downstream drivers of health. To what extent do you all think that nature of our training of health workers limits their ability to fight for changes that make a difference? And Camila, maybe do you have any thoughts on this, given the closeness of your work to medical training, especially?
And that Camila has written papers about this.
No, yeah, I think it absolutely, to that question asker's point. I do think that what we talk about and what we introduce, and the curriculums we design, absolutely help to shape the conversations we have and the future orientation that our learners may have. And so, to your point, I do think that not speaking about the deeper structural drivers of the patterns of disease that we see absolutely limits the ability for folks to see the ways in which they might be able to intervene on those structural drivers, as well as the more downstream social determinants of health and negative health impacts. I do think I have gotten to learn from a ton of incredible mentors and colleagues and learners in the few years that I've been doing this, about different ways to approach this type of learning. And I can say that even in the amount of time that I've been teaching on this, primarily to folks that will become clinicians in the future, has been about 9 years or so. And even in that time, there has been a pretty significant shift in how the audience that I work with are coming in with a lot more baseline understanding of structural drivers of disease, like racism and other systems of oppression, even in that short amount of time that I've been doing this work, not to mention folks who have been teaching much longer than that. And so I do think that in some spaces, I recognize I'm in one pocket, right? This is not necessarily reflective of the whole country or beyond that. But even just watching that shift in my local population in terms of what are the questions that folks are asking, what are sort of the ways in which my learners are pushing me to challenge them more on how structural drivers could be intervened on and how to think creatively in doing that, is something that has actually been quite encouraging for me as an educator. Although I'm not sure if I've been able to find, a published paper to reflect that same arc. It's something that in my personal life, I feel like I have seen my students really come in with a lot more information from other disciplines, bringing in their lived experience, and really pushing the entire community, learning community, which is another reason diversity is so wonderful, right? That whole learning community benefits from folks that are really asking these questions about how is it that structural drivers really push us and might constrain what we do day to day. This is, again, thinking about clinicians in particular. And so to that point, I absolutely think that it's imperative that we continue to find ways to talk about these structural drivers thoughtfully and push for our learners to understand the ways in which they impact the patterns that they're seeing, downstream.
In the framing of that question, we heard the social determinants of health, which of course is a framework from the space of public health largely. David, can you speak some to the role of public health departments in helping to address these disparities, especially since their mission is more explicitly focused on influencing policy to improve community health and reduce disparities? How might they be part of the solution? How might they partner with healthcare institutions to influence change?
They are a critical part of the solution, because health is not just about clinical care. I saw another question in the chat relatedly that referred to the report from the WHO by Michael Marmot that says, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? There's a recent report from the National Academy of Medicine entitled Integrating Social Care into the Delivery of Healthcare. And that if we want to be effective in delivering care and improving health of the population, clinical care is important, but it's not enough. It's not sufficient. We need to think of improving the conditions in which people live, learn, work, and play. Let me give you one example. 1978 study. So this is old school, been around for a long time. Randomized controlled trial, 244 patients with hypertension, 80% of them African-American, randomized to 3 conditions. 1, go to your doctor, get your medication, go on your way home. The second condition, got your medical treatment from your provider, and then went to a course for 12 weeks where a trained health professional provided a lecture about high blood pressure. And the third group got clinical care, and then they got lay people, local people, non-professionals from the community, trained them in the basics about understanding blood pressure and why it was important to take their medication, but also trained them in identifying all of the resources that existed in the community to help people with problems that they faced. And these lay community workers made home visits. And 7 months later, when they tested the 3 groups, those who had gotten the lay community intervention knew twice as much about blood pressure than any of the other 2 groups. They were taking their blood pressure medication more faithfully than any of the other 2 groups. And blood pressure medication was twice as effective in controlling blood pressure in this group. What was different? Their problem was understood and addressed within the context of their lives, and it made a difference. And health departments and even healthcare systems can be more active in addressing the larger social problems. And I encourage everyone, you can Google it online, you'll find it, Integrating Social Care into the Delivery of Healthcare, a report from the National Academy of Medicine in the last few years that lays out a broad range of strategies that are being used and are working across the country to make a difference in the lives of patients.
David, I know I've seen a couple of requests in the chat for some of the studies that you've been citing. Are there any quick answers on where we can direct folks to a bibliography, or do we just need to spend about
can we tell them, Karishma, can you tell them how they can get our paper? We have written the paper that many of these things are in.
That paper is in the chat. I will link it again before we wrap up here. And yes, a lot of what has been referenced that David has mentioned as far as is in the bibliography of that paper. So that might be the most concentrated place to go for it. Okay, moving forward. Marie, this one is for you. Are there opportunities, to your knowledge, to integrate knowledge and education of implicit bias, cultural sensitivity in current development of quality measures or programs for value-based purchasing to improve health outcomes and reduce health disparities? And Camila or David, if you have thoughts on this, feel free to jump in as well.
The name is blanking, but there are a few programs out there that do talk about how to mitigate bias. But I think it's also important to note that students or medical students are really excited and are eager to learn. They have really, when you think about like race-based medicine and like racist algorithms and tools, like medical students were at the forefront of that movement, making those changes. And so I think part of that is tapping into this network who's excited to make structural changes, and also recognize that there's so much more to be done. In the work that I do in the qualitative component, lots of students talk about racial bias training is often like a day workshop, or it's the beginning of medical school. So like having intentional, thoughtful efforts, if we look to the divine solution, as David pointed out earlier, for students to tap into, being really intentional about that, I think is so important, not this kind of check mark item that we do to make sure that students are getting those competencies, but really making sure that students are engaged and learning because folks are excited. And so bridging that gap and finding ways to do that in effective ways, super possible.
Sticking with
I
that,
would just add briefly that one other innovative thing out there that has implications for training is what the University of California, Davis has done when race could not be used in admissions in California. They developed an alternative system that every applicant gets an adversity score of the exposure to adversity they've had, and without using race, they have been able to dramatically increase the number of African Americans and Latinos that they accept. So there are ways in which we can be creative. And I'll also mention that Camilla mentioned Dr. Jack Geiger. He is one of my heroes. And yes, he did write he reviewed for one of the commission papers for the Unequal Treatment Report. He reviewed the paper that summarized the scientific evidence at that time. But he's also one of the co-founders of the first community health center in the United States, right here in Columbia Point, Massachusetts, and then directed the second center in Mount Bayou, Mississippi. And one of the things he did, and I want to cite what he did just because we need to be innovative. One of the things he did is that he would write prescriptions for patients in Mount Bayou, Mississippi, for groceries, and the prescriptions would be paid for at the local supermarket, but from the pharmacy budget of the healthcare center. And the governor of Mississippi heard about this and sent a complaint to the Department of Health and Human Services, and they sent someone down to investigate what Dr. Geiger was doing. And he told them in all of his medical training, all he had been taught is that the right medication for persons who were malnourished was in fact food. So he was providing the right medication. But I cite this just an example of the creativity that some of those pioneers brought to the work that they did. And we need to think outside of the box to make a difference for our communities.
Seems obvious, but worth saying loudly and saying repeatedly, right? This will probably be the last question we have time for, and it has to do with, in your opinions, how do we use incentives and the carrots and the sticks here? There are some ideas here that maybe we should be using shame for individual providers to show how their behaviors are not in line with the outcomes that we want to see. Alternatively, is there use of incentives or benefits for the powers that be that are benefiting from the current system to change the status quo? So how do you think about carrots, sticks, incentives as structural drivers of outcomes?
I'll jump in quickly on this only because I have to run to another meeting. We need to bring all tools on deck. We need to use every strategy. For some people, we need incentives. For some people, we need to have the stick. But we need to have an all points, all hands on deck approach to ensure that we are pulling every lever that we can to ensure that every person is treated with dignity and respects and gets high quality medical care.
Thank you, David. I know you're going to have to leave right at the top of the hour, so I'll say goodbye and thanks on everyone's behalf now. Camila, Murray, any final thoughts on that front?
I think it might be helpful to look at the incentives that exist, particularly in sort of what questions are pursued and what types of projects are funded, and thinking about whether or not there are ways to fund some of the processes that we think are particularly helpful. For example, if we're really interested in improving education around this, changing behaviors, seeing if there are funders who would be willing to fund that, to think about those processes critically. I think it would be great to have incentives to actually break silos and work with people in other spaces, work with communities all of that does take resources, and it does take time to build those relationships and to build that trust to do that work in an effective way. And so it would be great if the incentives that already exist, I'm thinking about funding primarily, but that's not the only thing, would be able to actually create enough, time and funding to actually do some of these things that we think might actually lead to some of these breakthroughs and innovative approaches to the work that we're thinking about doing.
Marie, any thoughts from you before we wrap up?
Yeah, I think both of those were perfect. Just add incentives to improve tracking of data, right? Like we've talked about that a lot, but improving our tracking systems. There are different measures out there, but what are the missing questions that we don't have to better track what we're doing now? So I think that'd be really helpful.
Thank you. I thank you to the audience for joining us this morning, afternoon, whatever time of day it might be for you. I apologize for not being able to cover all the questions, but several of the topics behind the questions are part of the paper. So I saw one of my colleagues at Urban drop the link to the paper. Encourage you to check it out and to continue the conversation with us about it and topics beyond offline, beyond our time together today. I'll wrap us up with that. Thank you so much. Have beautiful days ahead of you, and thank you to my co-authors and colleagues for joining for this conversation. Very much enjoyed it.
Thank you so much.
Thanks, Karishma.